This is our intro. We're starting at Unit 1 intro. Long time ago. So what mechanism produces normal tracheal breath sounds? And that would be turbulent airflow through the large airways. So, of course, the trachea is the largest airway, and that airflow is going to be turbulent or at least mixed or transitional. So that turbulent airflow would cause normal breath sound. Sudden openings of peripheral airways would create what breath sound? Can y'all hear me?
Yes.
Okay. I didn't know if you couldn't hear me or okay, just making sure.
I'm just like a deer in headlights.
All right, I'll let y'all study intro. Okay. What about the passage of air through narrowed airways?
Wheezing?
Yeah, good. Yep, wheezing. So not starter because that would still be a tracheal breath sound. So yep, wheezing, and then air passing through secretions.
Is that crackles?
Yep.
Or bronchi? Okay.
Bronchi. Mm-hmm. So the sudden opening of peripheral airways, pop, 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 snap, crackle, pop, would be crackles. Okay. All right, Taylor, remember a little something, something. So auscultation of the lungs is? That would be listening of the thorax to identify breath sounds. What equipment do you use to auscultate? Stethoscope. Yeah, so that's the most popular method of chest evaluation that we do. What is the act of tapping on the thorax? What is that called?
Percussion.
Which one? If you're tapping on it, percussion. That's percussion. If you're tapping, you're percussing the chest. And when you are percussing the chest, what are you evaluating for?
Resonant sounds.
Resonant sound. Mm-hmm. And so when would you hear hyperresonance?
When there's like a pneumothorax.
When there's more air.
Yeah.
Right? So pneumothorax or something like that. A patient who has COPD or is barrel chested, they're hyperinflated, that would be a reason that you would hear more air. And of course, not air would cause hypo or dull resonance. So if you're percussing over bone, if the patient has an pneumonia or consolidation, a tumor, or something like that. So, and of course, visual examination is just visual exam. Why would you palpate the neck?
To feel where the trachea is.
And why would you do that? Like, what could be an abnormal finding?
Because there could be a tracheal shift, which would be could either be
pressure,
a pneumothorax, or a collapsed lung, or atelectasis.
Mm-hmm. Yep. So if you could have a tracheal shift one way or the other, one direction or the other. Of course, a tracheal shift away from the problem would indicate a pneumothorax, or away from the affected side would indicate a pneumothorax. A tracheal shift towards the affected side would indicate usually a massive atelectasis or lung collapse, the other lung collapse. Okay. And of course, when we touch the chest, when we palpate the chest itself, the thorax, what are we evaluating? Or what is going to be the result of us palpating? What's the technique of palpation? What do? We just touch it?
We tap it.
That's percussion. That's the red one.
Palpating is just touching, right?
Yeah.
So that's what I'm asking. So we just touch it. We don't. That's it.
Firmitus for
Yeah. So
vibration.
that's when we use again our palmar or ulnar aspect, and we have our patient say 99, 99, 99, 99. You're touching the chest, but you're touching for what? You're trying to evaluate for firmitus, like AJ said. You're touching to feel the vibrations. So, and of course, you would feel more vibration if there's consolidation, pneumonia, increased secretions, and then think about the congested child, and then you would feel, of course, less vibration if your patient had very air-filled lungs, they were hyperinflated or had a pneumo or something like that. Okay, but when you palpate, you have to have your patient say 99. You don't just touch the chest and the patient does nothing. That's where you have them say 99, 99 as you move your hand throughout their chest field, their lung fields, and you're assessing for firmitus, tactile firmitus. That was way back, long time ago, right? All right, number 3, an inward depression of the sternum describes. That would be pectus excavatum. Think cave inward versus pectus carinatum, which is the outward protrusion. What is kyphosis?
Curvature of the spine.
Which way?
Hunchback.
Yep. So they would have an increased AP diameter. The curvature would be upward, and then the spine would kind of sway inward just above the butt. And a scoliosis would be
The S curve.
the side to side curvature of the spine. What's flail chest?
Like broken ribs or
Several. Yep, several broken ribs. Good. So let's keep it in lead. Patients on extended bed rest are at risk of all of the following complications, except good. So of course they can get bed sores from not moving, collapsed area of the lungs because they're not taking deep breaths, which would support your increase or your decrease, lung volume. But usually a heart attack is not associated with bed rest. Okay, how often should a TID treatment be given? Good, that would be 3 times a day. How often should a BID treatment be given? Good, that would be 2 times a day. Good job, guys. So how does that differ from every 12 hours, or what would the abbreviation for every 12 hours be?
Q12. What is it? Q?
It would be Q12 or Q12 hours, right? So of course we know that if we give a treatment or medication or whatever 2 times a day, it would still be about every 12 hours. Usually in the hospital settings, it's 9 a.m. and 9 p.m., but still on paper, that differs from Q12. If you want it literally given every 12 hours, you would put Q12. BID would be 2 times a day. How often should QID treatments be given? Good, that would be 4 times a day. Every 2 hours would be Q2, of course, and we've already gone over 2 times a day and 3 times a day. Okay, hypertrophy means that would be the increase in size or muscle mass. What's coming for you, Taylor? Tracheotomy means good. So that's the actual surgical procedure for making an incision through the neck, whereas tracheostomy would describe the opening through the neck to the trachea. Because remember, those patients have a stoma. The stoma is the hole itself. So a tracheostomy is describing the opening as well. Tachypnea means good job. So what is the medical term for rapid heart rate?
Tachycardia.
Tachycardia.
Tachycardia. What's the term for slow respirations?
Brady.
We're now on mute.
Predicting. And what is the term for slow heart rate?
Bradycardia.
Bradycardia. Good. What numerical value would indicate a decreased heart rate?
You are muted.
Below 60.
Below 60.
Yep, below 60. And what numerical value would indicate tachycardia?
Above
100.
Above 100. Mhm, good. AARC is it's an organization for respiratory care practitioners. A certified respiratory therapist is just that, a certified respiratory therapist, just as a registered respiratory therapist is a registered respiratory therapist, or RT, respiratory care practitioner. So they're not an entity, they are people. They're what you guys are going to be. And the testing organization for respiratory therapy is called what?
NBR.
NBRC, right? The National Board of Respiratory Care. The retrosternal space is found behind the sternum. So if it were the space above the sternum would be known as, you have a notch there.
Suprasternal?
Yeah, suprasternal notch. Super meaning above. Which is not a cause of increased tactile premises. And now you all know because we talked about this. Well, it is the pneumothorax. So let's think about this. Tactile premises. Well, how would you assess for tactile premises?
We just said doing the 99.
Right. So that's called what?
That's Is that palpating?
That's palpating, right? So, and think about if your child is congested and they're talking, when do you hear more rattling?
When they're
Congested.
sick, when that all that gunk is moving around.
Yeah, when there's more congestion, when there's more stuff in the lung. So for any of us, and you guys palpated each other's thorax, for all of us with normal
You are
lungs,
now muted.
did you feel a lot of vibration?
No.
Didn't have, no. Because there's not a lot of stuff in there for that sound to bounce against, right? So if there is a pneumothorax, that would be even more air in the lung. If your patient is hyperinflated, had a barrel chest. Well, we tried that, but of course it's very hard to hold your breath and talk at the same time. But we tried to kind of experiment with that. If you guys remember, we had you guys like hold your breath and then try to create noise, right, for vibration. And sort of worked a little bit, and you were able to notice the difference, the decrease in vibration, right? So the more air in the lungs, the less vibration that you will feel. The more stuff in the lungs, whether it be snot, whether it be consolidation, pneumonia, tumor, atelectasis, that's going to be more stuff for that sound, those sound waves to bounce off of. So that's going to cause more vibration. So again, it's just like your kid who's sick. There's more stuff in their lung. There's more snot in their airways. So that's going to cause more vibration. So air would be less vibration, but more resonance. Anything other than air would cause more vibration, but less resonance. And more vibration, but less sound. Any questions? What is stage number 1 of patient clinical interaction? That would be your pre-interaction stage. So remember to go back and study your stages of patient clinical interaction. So remember, we have to do our pre-interaction stage, which does include our chart assessment before we even go into the patient's room and introduce ourselves and start interacting with them. This principle requires that we go beyond doing no harm to actively contribute to a patient or one's health. All right. So that would be, of course, beneficence. So make sure you go back and study those terminologies. There were quite a few in your intro unit. If a patient weighs 180 pounds, how many kilograms do they weigh? That would be approximately 81.8. So, and as we recall before, if you try to just divide it by 2, your answer is not going to be off. I know that wasn't a lot of time to do math, but what's your formula? How do you convert pounds to kilograms?
Divide by 2.
Divide by 2.2.
Divide by 2.2. And if you were given their weight in kilograms, how would you convert that to pounds?
Multiply.
You multiply.
All right,
Do
multiply
it
by 2.2. So that was not on your math sheet, but remember that's the formula too that we learned. What's the formula to convert centigrade or Celsius to Fahrenheit? Good. That would be your 9/5. If you choose not to multiply by a fraction, What does that 9/5 convert to?
1.8?
1.8, right? So that would be 1.8 times your Celsius plus 32, okay? So, and for questions like this, you can automatically eliminate the yellow and the green, because what temperature are you looking for? What temperature is your answer going to be in?
Fahrenheit.
Fahrenheit. So you need a formula that's going to give you Fahrenheit. So you're looking for a Fahrenheit equals formula. So you can automatically eliminate anything that's a formula that's going to give you an answer in Celsius. You already have your answer in Celsius if you're trying to convert from Celsius to Fahrenheit. This act sets standards regarding the way healthcare information is communicated and transmitted. That would be HIPAA. Good. How many P's in HIPAA?
How
2,
many people you said?
How many P's?
2,
Yeah, sure.
1,
1 P, 2 A. What's the stand for?
Accountability Act.
What?
Health Information Portability Accountability Act.
There you go. Good. Yep, good job. Wake them brains up. It's not that early. It's 9 o'clock. Late inspiratory crackles on auscultation of a patient might indicate. Good, all of the above. So, and just like the question about the, I think it was which is not a cause of increased premises, if you can lump disease processes or illnesses or conditions together, chances you need to find the one that's not like the others. So in this case, atelectasis is a consolidation, is collapse of the alveoli. That alveoli, possibly part of that lung, is not allowing airflow to go through it. With pneumonia, same principle. Of course, it's a different disease process. It's caused by something different, but there's less airflow as a result of gunk being in the alveoli, so it's not allowing sufficient airflow. Pulmonary fibrosis, these people have restricted lung disease. Their lungs are stiff and fibrotic. So, and again, you also can think about what is causing this crackling sound. Like on question number 1, it's the opening of the peripheral airways of those alveoli. So they would have to be closed. That would indicate that they're closed before the patient takes a nice deep breath in. What could cause the alveoli to be closed or not filled with air already? Atelectasis, because they're closed. So if the patient takes a big breath, that's going to pop open those peripheral airways and the alveoli. Pulmonary fibrosis, they have these stiff fibrotic lungs. If they take a deep breath, it's going to pop those alveoli and peripheral airways open. And same thing with pneumonia. They're not collapsed necessarily, but they're filled with something other than air. So if a patient takes a deep breath, it kind of pops them open, kind of creates a better pathway past those secretions. So look for the one that's not like the other. Okay, breath sounds with a low pitch and soft intensity auscultated over the peripheral lung are. Those are your vesicular breath sounds. So again, remember that vesicular breath sounds are heard in the outer parts of the lungs. So you're going to hear over your bronchial breath sounds. As you go out towards the periphery, you're going to hear those bronchovesicular breath sounds. And then, of course, out in the periphery, they get softer, lower pitch, and those are your vesicular breath sounds. What are adventitious breath sounds?
your abnormal breath sounds.
Right. So that's not necessarily talking about the location. And also typically when we talk about vesicular breath sounds, we know where you should hear vesicular breath sounds. So that those terms themselves, when we use them in the clinical setting at least, we're referring more to what type of breath sound that we're hearing as opposed to where. We already know where we should hear vesicular breath sounds, or we should know where we should hear vesicular breath sounds. And that's really typically where we listen with our stethoscope. So vesicular can relate to the location, but we also use that term to describe just a normal breath sound. Then adventitious relates to it being an abnormal breath sound. Of course, you would hear, we already described where you would hear bronchovesicular breath sounds. And of course, you would hear tracheal breath sounds over the trachea. Normal body temperature is good, 37 degrees Celsius, or
98.2 Fahrenheit.
right, 98.6 degrees Fahrenheit. Good job not picking 98.6 degrees Celsius. So the best place to discuss a patient's condition would be
No. Stop. Back.
good, that would be a report area. So of course, in some cases, they have bedside report, but per textbook in, in most situations, you want to give report or discuss the patient's condition in a report area. Because again, like we talked about way back when we discussed intro, what if there are, the neighbor? What if the neighbor's in the room? She's not a family member. She's not privy to that information. Or if the patient they're cohorted, they have another patient in the room with them. So if it's not required to do bedside report, you don't want to do bedside report. You want to give report or discuss the patient's condition in a report area, in a private area. Taylor's keeping her lead. Code blue means that would be cardiopulmonary resuscitation. Who says I'm not a patient? We don't call anything for that. We just fix them unless they do need a code called because they're either not breathing or their heart has stopped. Different hospitals have different codes for a missing child. Sometimes, like for an infant, it's code PINCS at some hospital or Adams, so it just depends on where you work. But a code blue for most facilities is cardiopulmonary resuscitation. If you don't know any other codes, make sure you know that one because that's pretty much a standard. Memorial, though, says code 5 for code blues, but they usually will, it differs for hospital, except code blue, that's usually universal, fairly universal. Okay, which of the following is the responsibility of the medical director? Good. So that is the clinical function and medical policy of the RT department. They're usually not involved in the day-to-day stuff, but they oversee the policies and just the, how the respiratory department works overall. Bronchoscopy is good job. So that is, of course, visual examination of the airways. Bronch or bronchus or bronchi are the airways, and then scopy would be visualizing or visual examination of it. You have an order for therapy you do not agree with. What should you do? And when we talked about the medical director, I was going to say, don't ever call the medical director, but I forgot to say it then, so I'll say it now. Don't ever call the medical director. Any question that you get, the answer is never to call the medical director. Okay. Again, they're not involved in the day-to-day activities of the function of the department. They oversee things. So don't call them. But you should tell your supervisor, make a note, document it, so forth, so on. What should you do if a patient refuses therapy? Good. Explain the consequences to your patient. That is, let them know, your doctor ordered it and this is why. If they still refuse, and this is the consequences of not taking, this is why it's ordered, this is how it will benefit you. These are the consequences of you not doing the therapy. Chart it. Always going to CYBs, cover our butts, make a note, and then report it to either your supervisor, your nurse, or even the doctor if they're around. You're not going to call the doctor unless it's something, like, for example, an ABG. If the doctor said, I want a stat ABG and I want you to call me with the results. In that case, you could give the doctor a call just to let them know so that they're not, waiting for results and the patient said, no, you can't stick it. So with everything in medicine, lots of gray areas. So you just have to kind of use your judgment and those critical thinking skills. But for the most part, you would explain the consequences to your patient, chart it, report it, move on. Okay, what does the root word cyan mean? Good, that would be blue in color, i.e. cyanosis, cyanotic. Posterior means that would be towards the back. Okay, so posterior is towards the back. Towards the front would be what term?
Anterior.
Anterior, right. Towards the side would be lateral. And dorsal means good job. So think about a dorsal fin. And dorsal and posterior, when speaking in general or like looking at a patient, of course, it would be in the same area, but specifically by definition, they are two separate terms, meaning two separate things. So that's it for intro. Good job, Amanda. Good job, Flo. Spotlight, your favorite. Good job, Taylor. I think we'll have some honorable mentions. Good job, AJ and Nikki, too. Okay, so make sure you guys go back and study intro. Any questions about any information from intro, anything that you guys have questions about, need clarification on, any questions from the Kahoot, now is the time for us to go over anything related to intro that we need to. No questions for me. No?
Just got to go over that whole.
Yeah. All right. Well, I'm going to take a cardiac break and then we'll move on to some cardiac rhythms. Yay.